Good afternoon, everyone. I'm Janice Whitaker. It's my pleasure to serve as the administrator for the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence. And welcome to the CGNE seminars. I'd like to thank Jenny Rank, our CGNE Education Program Specialist, for her amazing assistance with planning and implementing the seminars. This program is provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Ross and Carol Neese College of Nursing in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Optimizing Quality of Mealtime Care and Outcomes in Older Adults Living with Dementia, a multi-level approach, will be presented by Dr. Wen Liu, Associate Professor and Director of Some Center of Aging Hub at the University of Iowa College of Nursing. Before we begin, we do have some announcements and disclosures. Penn State Ross and Carol Neese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Participants with a valid RN license who attend the entire program can earn 1 contact hour. Partial contact hours are not awarded. To earn contact hours, Zoom in and out times will be recorded, and the post-event evaluation must be completed within 1 week of the seminar. Certificates will be emailed to RN participants meeting all the requirements within 1 month following the seminar. Just please be aware that the seminar is being recorded. If you have any comments or questions for our speaker, you can enter them into the chat, and Jenny and I will be keeping an eye on that. Or you can raise your hand, and Jenny will unmute you so you can speak aloud. And we do encourage participation, so please feel free to raise your hand and be unmuted so we can engage in discussion. The post-event evaluation link will pop up in your browser when the webinar concludes. So you can complete the evaluation at that time, or it will be emailed to you within 24 hours and you can complete it then or anytime within a week of the seminar. If you have any questions or concerns, please feel free to reach out to cgne@psu.edu. So next I'd like to introduce Aza Al-Hazari. She is one of our wonderful affiliate graduate students. Aza is in her 3rd year of her PhD program with a focus on older adults who've experienced strokes and cognitive impairment. Thank you for being here today, Aza, and for introducing our speaker.
Thank you, Janice. So I would like to introduce Dr. Wen Liu. And Dr. Wen Liu is an associate professor at University of Iowa College of Nursing. She graduated from Shandong University in China for her bachelor's and master's degrees in nursing, and University of Maryland at Baltimore for her doctoral degree in nursing. Dr. Liu's primary program of research focuses on optimizing mealtime care quality and outcome in older adults with dementia and their formal and informal caregivers. Her work has been funded by the National Institute on Aging at NIH and foundations. She has published more than 50 peer-reviewed high-quality papers and mentors students in research across levels, programs, and disciplines. Dr. Liu has been serving on multiple regional, national, and international work groups to translate research evidence and promote dementia care practice. Her contributions to gerontological science and education are acknowledged through multiple awards. including the 2022 Midwest Nursing Research Society Harriet Worley New Investigator Award and the 2022 National Hartford Center of Gerontological Nursing Excellence Distinguished Education in Gerontological Nursing. Dr. Lu was recognized as a fellow at the Gerontological Society of America in 2023 and a fellow at the American Academy of Nursing in 2024. So welcome, Dr. Winlow.
Thank you. Thank
Thank
you
you.
for the introduction. And then thank you very much for giving me the opportunity to present my work in this platform that's sponsored by the CGNE. I'm very happy and honored to be here. Janice, will you be able to see the screen? Well, just a quick check before I move forward.
Yes, it looks great.
Okay, perfect. Thank you. Yeah, so today I wanted to really briefly share my work around optimizing mealtime care and outcomes in people living with dementia using a multi-level framework and how we addressed the different levels of factors and try to develop interventions modifying those different factors. I started with just a briefly background of why I'm interested in mealtime and nutrition in the nursing field. So when I started rotation in nursing homes and hospitals as an intern nurse, I was imagining mealtime for older adults would be a happy moment, where whether for people who were independent or when they were receiving assistance or having partners to eat with them. But the reality has been very different. People who have cognitive impairments and also functional impairments or decline, they will not really be able to get oriented with what's happening in the chaotic or crowded dining area. And some people did not know how to get started with mealtime. Other people don't recognize the food in front of them, does not have good appetite. And when they are provided assistance, they usually have a lot of resisting behaviors, not knowing, what the assistance is about and how they are going to respond to that. So I started my research trajectory when I was in China, where I worked on translating and validating a tool to assess mealtime challenging behaviors and understand, what those behaviors are, how people are having different levels of challenging behaviors depending on their disease trajectory. And then I moved on to Maryland for my PhD degree and then joined Iowa as a faculty. When I was in Iowa, I also completed a certificate focusing on translational and clinical investigations. That's particularly useful for behavioral interventions using clinical trials for people living with dementia. So wanted to just give a big overview of where I am from with this line of research. We used the social ecological model. For people who may not be familiar with that, it's a model to look at the multi-level factors that may influence a particular outcome. For me, in the scenario of mealtime care, it's the factors at the individual caregiver, environmental and institutional or facility level, all of those factors, how they impact the vulnerability to stressors for people living with dementia, and how staff caregiving or family caregivers approach could modify all of those different level factors in order to improve resident individuals' mealtime behaviors and further improve their nutritional outcomes and food intake. I wanted to share a few projects that we did, all around being supported by this big picture of conceptualization. So first we understand the different levels of factors and then the measurements that assess all of those different concepts around dyadic interactions during mealtime. And also we categorized the temporal relationships between caregiver approaches and resident outcomes in the context of nursing homes. And lastly, we developed an intervention to address some of the modifiable multifaceted factors to improve mealtime behaviors and food intake. First, this is the framework we have been using to really understand for each individual, what are the factors that may impact, their behaviors and their interaction with caregivers and family caregivers or care staff, and how those different factors may impact their outcomes and interactions. We looked at resident level, caregiver, other resident level factors, and environmental level, as well as institutional and policy related factors. Some of the findings we have found is that for residents, the important factors around that is their physical capability or physical function and their cognitive stage. For interpersonal level factors, the caregiving approaches from care staff, whether that's task focused or person centered, resident focused, and whether that's focusing on following their preferences, is very critical. And environmental level, the environment to the person's needs and the fit in between environment and person needs is critical as well, in addition to the cultural differences, social preferences and their physical environment, how well the environment is supporting the residents' needs and activities. And we had some articles that supporting the role of those different levels of factors around at the 4 different levels. And we also had a study, that the last one that I shared over here, a study that we interviewed the nursing assistants and in terms of their perspectives of what you think are important facilitators of barriers. And we were able to use this same framework to conceptualize their evidence-based strategies. So, I'm happy to share more and then about the findings later on if anyone is interested. We also moved on to measure those concepts, because it would be hard to, without a valid measure, to understand, what is changing, what is not changed, what do we want to make a change through some interventions or training or education program. So we looked at, we used the same approach at the multi-level perspectives to understand the measures that are used to assess different concepts. First, we had a couple projects looked at resident chewing, swallowing ability and eating ability, as well as mealtime behaviors, to look at what are the skills available to assess those different important concepts. We also had another project that we looked at caregiving knowledge, attitudes, and behaviors, including both family caregivers and formal professional caregivers. And lastly, we looked at measures or tools that assess dyadic interaction and physical social environment in the field of dementia mealtime care. And what we found is that there isn't much that is really looking at the dyadic interaction. For example, when staff is providing some verbal or nonverbal cues, how residents is responding to staff care approaches, and then how staff is responding back to resident responses. It's dynamic rather than static. And we were wanting to measure that, but there hasn't been anything available. So we moved on with developing a couple of tools to assess some important concepts. One of the two we developed is a caregiver level measure that look at mealtime engagement scale for indirect care providers of nursing home residents with dementia. We used a couple of different techniques to validate and develop the tool. One is the classical task theory. If that's not familiar to some of the our attendants here, it's an approach to look at the skill level performance. Is the skill as a whole package is performing well performing in a valid and reliable way to measure mealtime engagement among caregivers. We also used the item response theory analysis to look at the same skill, which is really to look at the item level performance. This item response theory an approach is being used to develop a lot of the promise measures that were sponsored by the NIH, if that makes sense. The goal is really trying to develop a shorter list of items and each item is high quality, performing well. And that's how, the idea is coming in with the two different types of approaches for measurement. And this is what it looks like. In terms of mealtime engagement, it really looks at how the caregiver is engaging them. All the behaviors are positive. And if, there are things, it could be also used as a checklist in terms of, did I do those behaviors? Is this a behavior appropriate for the resident to deliver more person-centered or residence-based care approach? The other tool that we developed, which we were really excited about, is trying to capture the dynamic interaction between caregiver and people living with dementia during mealtime. And it's called QUED. It's a coding scheme where we had to initially use videos to analyze the behaviors. And this is what we found. We looked at resident mealtime behaviors, including both positive behaviors, functional impairments, and resistive behaviors that include both verbal and nonverbal. And we did find, while people show a lot more challenging behaviors as what I initially observed in my, in rotation as an intern nurse, we also measured and captured a lot of the positive behaviors that residents shows during mealtime. And for staff mealtime care approaches, we capture a lot more person-centered care approaches, which is great, and some task-centered approaches. We focused further on the nonverbal behaviors among staff and found that the staff care approaches did kind of try to modify factors at different levels. Like there are some approaches targeting on adjusting resident functional cognitive abilities and some on modifying the dyadic interactions and relationships. And there are some focusing on modifying the physical and social environment to provide more support, to make it more supportive for residents' mealtime experience. The other thing we looked at was the food intake attempt. We care a lot about how much they eat. That's very important as a nutritional indicator, but we also, in this study, we really care about how well people living with dementia are engaged in the mealtime instead of being passively assisted by care staff. And we found that residents were able to initiate more than half of all the food intake attempts. When I say food intake attempt, I mean is resident or staff initiating a bite of food or a drink of liquid. And here, staff were helping or initiating less than half, and residents were initiating more than half of those attempts, including both intake of solid and liquid, which means residents have a great potential to, start their own food intake attempts with staff assistance or without staff assistance and cues. So that gives a lot of confidence in terms of that residents can do something with help, and there's a way to maintain or restore their autonomy and function during this interaction. And those are some of the papers we developed to describe the interactions, including verbal and nonverbal. So I'm happy to share more or the full text if anyone is interested. Right now, we're doing another project in terms of the measurement to really make the measures more pragmatic and feasibly used in the clinical. QUED requires a lot of labor to time to code the videos, and we had to collect the videos. So now we are trying to develop 5 different brief skills to measure each of the 5 concepts that are important to capture the interaction. The goal is not really to evaluate staff performance, it's really try to understand how staff and resident are, interacting to form a better relationship and form to have better mealtime experiences for both. The other thing I wanted to share a little bit more is the temporal relationship analysis. I will briefly describe what it is, but I promise this won't be very statistics heavy or quantitative heavy. So the idea is that we want to understand when a staff or caregiver provide a certain approach, like a verbal cues, such as would you like some of those for your meal, or would you like to try more? Some of the verbal and nonverbal cues, what would happen to resident? How would the resident respond to that verbal and nonverbal cue within the 5-second window, within 10, within 15? So we wanted to kind of understand that dynamics of behaviors. And first, we looked at how staff approaches may impact resident behaviors, and we find that following staff person-centered care, resident, if you can see here, those two bars that I circled over here in the brown box, following staff person-centered behaviors, whether that's verbal or nonverbal, we find that resident positive behaviors, verbal, nonverbal, were higher, were more likely. The darker gray bar shows the likelihood or the chance of a resident behavior occurring within the 5-second window or within the 10-second window and within the 15-second window. And the lighter gray bar that's next to the dark bar is the frequency or the chance that's a behavior happening outside the window bar, outside the 5-second, 10, and 15-second windows. So we see following staff person-centered approaches, resident positive behaviors were more likely immediately after, and also up until 15 seconds. In addition, resident resistive behaviors were more likely as well. So there's like a tricky piece over here. It means, resident behaviors is not always helpful for all types of behaviors. Resident shows resistive behaviors following person-centered care, but person-centered care can improve or trigger or enhance more resident positive behaviors. We also find following staff person-centered approaches, whether verbal or nonverbal, their functional impairments, resident functional impairments were less likely, which is a good outcome that we all wanted to reduce. And we also see the bars, the height of the bars is higher for verbal versus nonverbal, which means staff person-centered verbal behaviors has a more strong effect compared to staff person-centered nonverbal behaviors for those resident behavioral outcomes. The other one, following staff task-centered care, we find the opposite results. Like resident positive and resistive behaviors were less likely, and resident functional impairments were more likely following staff task-centered and nonverbal and verbal approaches. And now we look at how the staff approaches impact staff-initiated food intake. And we see that staff-initiated food intake were more likely following person-centered care and less likely following task-centered care. So that means overall staff approaches have impact on resident mealtime behaviors, as well as impact on staff-initiated food intake. But staff approaches don't seem to have a lot of impact on resident-initiated food intake, because it seems equally in terms of frequency, whether staff provided person-centered care or task-centered care. Then we wanted to move forward to look at some of the impact of resident behaviors on resident food intake. First, following resident positive behaviors, resident-initiated food intake were more likely. And following their challenging behaviors, their food intake were less likely, which makes sense. And then following resident positive nonverbal and functional impairments, we find staff-initiated food intake were less likely. And following resident challenging behaviors, staff-initiated food intake were more likely. So there's like some interesting findings overall in terms of staff approaches seem to have more impact on resident mealtime behaviors. and not so much on resident food intake. But resident mealtime behaviors seem to have more impact on resident food intake, especially those resident-initiated food intake, which is an indicator of resident function and autonomy. And those are some of the publications we had describing those findings. Our end goal is really try to develop multi-level strategies to improve mealtime care quality and outcomes. So we also looked at the literature and find what are the available evidence. Is there anything we can use to create evidence-based practice, evidence-based strategies or interventions. And we were able to also synthesize and analyze the existing strategies using the multi-level model as well. There are resident level training therapies such as Montessori-based activities, spaced retrieval activities for residents to improve their muscle memory and improve their functional performance related to mealtime activities. And there are staff training, mealtime assistance, and dietetic interactions as well to educate staff in terms of how to provide better assistance during mealtime. And there are different options or modifications of the food delivery types, providing different diet, and also some of the environmental strategies in terms of the dining room, in terms of like noise, light, or putting something like a fish tank or giving music before and after to help with mealtime performance. And there are also institutional level interventions depending on particular institutional structures or infrastructures, especially related to mealtime as well. But the gaps we find in terms of interventions for mealtime is that there isn't much that's focusing on person-centered or resident-based care delivery. Person-centered care has been highly recommended across the board by different foundations, different national plans, and to highly recommend this type of care for people living with dementia. But there hasn't been much that's done during mealtime or for nutritional support. So we were aiming for developing something to optimize person-centered care. And this is the protocol we developed that tried to address the different levels of factors. It's a relatively complex intervention because it's multi-component, step by step. But we wanted to throw this program to kind of engage the stakeholders in nursing homes or facilities, doing some environment and policy level assessments to see if there's anything we can feasibly change, and then deliver person-centered care education to direct care staff and providing ongoing planning, support, and mentoring for them to be able to kind of empower them to provide care to each of the different individuals with living with dementia and needs assistance during mealtime. So a few more about the optimal is that we developed this principle called recipe. Hopefully that's better for people to remember the key principles of person-centered care. And this is how we operationalize the philosophy of person-centered care into mealtime. It includes like showing respect, creating environment, offering choices, supporting independence, acknowledging preferences, and maintaining engagement. The main goal, as you can tell, is really try to foster a supportive mealtime experiences during that period of time. And you can also see the recipe principle can be operationalized in the care of other activities of daily living, not just limited to mealtime. But at this point, our program has been mainly looking at mealtime and nutritional support, but there is potential to adapt the principle and also optimal into other activities of daily living care. So from our initial findings, we looked at the impact of optimal on resident outcomes, and we find there's definitely reduction in mealtime resistant behaviors and functional impairments, as well as it can maintain not really having a lot of deterioration in eating independence, and also improved food intake amount, especially for this group. the dotted lines are the group who need extensive and a lot of help. It seems there's like less bouncing back after reduction, more potential to be able to sustain the effect for this group who need extensive and a lot of assistance during mealtime. So an overview of all what I did around using the multi-level framework is that we developed that conceptual model to guide everything that we want to look at down the road. And we used the model to also help find out what are the measures that needs to be addressed or developed and try to fill that gap. So we are able to measure the key concepts and link the associations between different concepts and identify what are the modifiable factors within that framework. And all together, we were able to develop a protocol that address different components on the different, throughout that whole multi-level model, and then develop and then test that in nursing homes. The overall goal, as I shared a little bit before, is try to advocate person-centered care, improve outcomes for both caregiver and the person living with dementia during mealtime, and most importantly, improve the experiences and maintain their function. And meantime, we hoped that could improve their food intake and enjoyment of the mealtime moment. And just a little bit about the next steps. We are trying to, work on getting secure funding for stage 3 efficacy trial for testing the optimal in nursing homes. We are also expanding the how optimal can be used and try to adapt the protocol into a home setting where we want to target family caregivers and people living with dementia at home and see how this protocol can be adapted to their needs, because we understand nursing home care staff and residents living with dementia, their needs and their relationships and the environment and the institution they are in is very different from how we look at family caregivers and their loved ones at home. Their relationships, the dynamics, and then the dining environment in individual nursing homes, as well as the limit of how long you can eat for breakfast, lunch, and dinner. What are the options you have for eating or for drinking, and then how much your preferences can be acknowledged and appreciated or followed is very different. So we wanted to look at how person-centered care can be implemented and used in different care settings. Other collaborations I just wanted to briefly share around mealtime and nutrition is we're working on developing a decision-making guideline for people living with dementia, using qualitative stakeholder interviews, quantitative survey data, and also literature review to kind of share, what are the important guidelines for people to make decisions from early on when they were diagnosed with dementia to the end stage of dementia, and what are the important things people wanted to have considerations in moving, forward as they live with this condition. The other one we are working on is a small business grant, where we wanted to design a app or protocol that can help and support the needs of family caregivers living in the community who take care of people with dementia, and understand more about the important information and support related to mealtime management. The other one that we are really excited about is that we have developed a multi-level component hydration program that's person-centered to particularly just improve hydration for people with or without dementia. This is focusing on all older adults, because we know in nursing homes and also in family home settings, people who older adults, whether they have cognitive impairments or not, there are different reasons that they don't get enough hydration. Oftentimes people were dehydrated, but they were not aware. Reasons like they forgot to drink, don't have good access to the drinking station or sources, don't have a cup that can hold their water or their drinks of choice, or they don't have enough choice of drinks. So we were trying to address those reasons and then developed a program to educate both family caregivers, direct care staff, and also older adults who are cognitive intact to learn about more in terms of maintaining hydration. And that can really help to reduce some of the consequences, such as urine tract infection, delirium, or some other health-related consequences. Yeah. So throughout the whole program of I talked about my primary research is really try to optimize mealtime care quality, including behaviors, dietic interaction, food intake, as well as hydration, getting enough in, but also meantime enjoy the food and maintaining your function, have a good experience of mealtime and drinking. So I wanted to acknowledge the help and the contributions from our care community partners, staff, residents, our team, and also our funding agencies. And mostly importantly is my team, peers and collaborators and mentors who helped me all along the way, and then were able to collaborate with me in a very supportive and collaborative environment. So that's all about what I want to say today. I'm happy to take questions at the moment, if there is any, and I can stop share from here. Those are the Chinese characters that my kids said and write. They mean thank you here. Thank you.
Oh, that's beautiful.
Yeah.
That's wonderful. Thank you for sharing that. And I should apologize not only to you, but to the audience for my slightly squeaky voice today. I'm just getting over some laryngitis, so I apologize for that. But thank you so much, Dr. Liu. That was such a tremendous presentation, such an important topic. Older adults living with dementia often have so many challenges. As you mentioned, the barriers to their nutrition, to their mealtime enjoyment, their whole experience with meals and food. And we know as human beings, that's such an important part of our lives, is food is an important part of our lives. But for people living with dementia and their formal and informal care partners, it can be a very difficult time. So thank you for this amazing presentation, but even more importantly, for all the tremendous work you're doing in this area. The breadth and depth of what you're doing is just fascinating and very important and very informative. So I'm thrilled that we have faculty, we have students, we have clinical partners. I see some directors of nursing and others on the call today. So I'm excited that they're getting this information from you. And I see that we already have some questions in the chat. So Clarice is asking, have you studied or plan to study the impact that communication and cultural differences have on meals and hydration, such as things like hearing impairment, non-English speaking residents, and things like that?
Yeah, thank you, Clarice, for that question. We have been collecting data on, whether they have their hearing impairment that may impact their communication, whether they wear devices that correct their hearing or not, and their level of impairment if not. We also collected their language, like primary, second language for people, for both caregiver and residents. But at this point, our sample hasn't been big enough in terms of individual staff and residents that were part of the mealtime interaction to analyze the differences. But we assume there will be, depending on whether the diet were able to use the same language, whether they were not able to understand each other verbally a lot. But in nursing homes, because our population are people living with moderate to severe dementia, a lot of them were not able to verbalize, whether in English or another language. So Like in our study, we find almost 80 to 90% of the communication between the caregiver and care staff and the residents living with dementia is nonverbal. So we think that, that may still have some impact in terms of culture differences, language differences. I think the impact is probably smaller in nursing homes compared to family caregiver settings, where there will be a lot of cultural, food-related cultural aspects that come in from both family caregivers and people living with dementia at home or community settings. So, but that's something, the data we have been keep collecting, and then we hope to analyze that when we have enough individual participants. Right now, a lot of our individual, analysis units are the meals. We can collect a lot of meals, but our residents are kind of clustered within the facility and also by meal. So we haven't been able to look at quantitatively, but qualitatively we have been keep looking at that. Thanks for the question.
Yeah, that's a great question. Thank you, Clarice. Cindy Heath is asking, is there a big difference in how the care is given to elders with dementia between the United States and China? Can you comment on that at all?
Yeah, for sure. My observations has been more than, how do I say, 15 years ago in China. I definitely think I talk with my colleagues in China. There's a lot more improvement in terms of the quality of care in nursing homes, and also plus the home care. A lot of technology has been used, lots more support to take care of this generation of older adults in China and also in the US. So I wouldn't be able to compare right now, China versus US, because right now a lot of my experiences is based on observation of US nursing homes. But I definitely think the type of food that are being provided, the way people eat is very different. The food utensils we're using here, fork and knife. In China, we probably use fork, not knife. We never really use knife on the table, like fork and maybe spoons for soup and also chopsticks for the most part. And
That's
people,
good.
if they won't be able to use utensil in my study and my philosophy, it's definitely okay to just use finger food.
I
So
was going to ask about finger food. Yeah, that totally makes sense. Yeah.
I think that definitely can go together, whether the culture is the same or different in terms of, we don't want it to critique residents because they cannot use utensil or assisted devices or utensil. It's definitely okay to use whatever they think is appropriate. So I probably wouldn't be able to tell a lot of details about the differences, but I think overall the choices of food and then how people eat using different types of utensils may be different. And that could link to their part of their experiences as well in terms of
Sure. I mean, culture is just such a huge part about, there's such a correlation between culture and food and mealtime and the whole experience of that for individuals and groups. So yeah, thank you for your comments about that. Tracy states that she loves the recipe principles and the ability to adapt that in other areas. I also wrote myself a note about that too. As a former director of nursing, I know that sometimes in helping staff remember key concepts, an acronym is really helpful sometimes. So whether it's, recalling all the different pieces of that recipe, or even being able to kind of post that, in key locations in the dining room or other places where staff are reminded of those different principles. You mentioned R was for respect, showing respect, E being creating a certain type of environment, C offering choices, I supporting the independence, P asking preferences, and E maintaining engagement. Can you speak a little bit more about how you came up with those particular principles?
Great question. I think it's a lot of work that has already been done. Like people are already doing this. I'm not really, I'm not the person like started with, we need to acknowledge preferences. People have been talking about we need to acknowledge preferences. We need to create a good environment. and then giving different choices so people are not just stuck with one choice, and then maintaining the engagement and then providing, and respecting throughout, no matter what you are doing, showing respect. And then, providing affirmative communication and then treating them as, as an adult. So I think all of those are out there. I'm just kind of trying to, identifying where they are, putting them together and give them a name. That's kind of giving the name is probably my only job, that I had contributed. But other than that, all of those are like has been done by people. Even now in different nursing homes, people are doing that already. They may not be aware, oh, this is what I'm doing, but I think I'm giving it a label that, this is like a good job doing this, keep doing that across the board in different types of care. So
Yeah, it's just, super helpful reminders and raising awareness and key concepts that are important when you're trying to create the most positive mealtime experience and optimizing their intake and nutrition. So that's wonderful. There's
I'm
another
curious
comment related to the recipe. Oh, go ahead, Jenny.
if I can quick interject. I'm just curious while we're on the topic of recipe. Dr. Liu, are you aware of any, I guess, kind of resources or like a website or even like a page that our attendees can kind of go to find that recipe kind of broken down that they could share within their organizations?
oh, that's a good point. I'm working on a manuscript in terms of describing how you define the 6 components, the 6 different pieces of recipe, and the examples or strategies. I'm happy to share, what's available in our protocol, in our MOP. It's basically coming from like how do you operationalize each of the principle? What are the different examples? And I'm happy to share that through a document. We don't have a website yet for this line of research. So bottom line, I can share the document we used that we teach the care staff in terms of what are the examples following this. And there might be one example that could address different principles of the recipe. So if anyone is looking for that, they can contact me or they can contact Jenny and I can share, the definitions and examples for each recipe principle.
That would be great. Thank you. And I did the email that everybody will get tomorrow. I did include your email address in that so that if anybody has additional questions, they can reach out.
And they can feel free to operationalize the way they think is appropriate. It doesn't have to be always, the way I perceive it. Sometimes, you have the big picture, the umbrella, but whatever is in there, you kind of have the bone, the skeleton. Now you need to fill in the content and the meat, and you don't have to just stuck with mealtime. I see, there's potential you can use it for other care. And if you're interested in that, I'm happy to talk more and see how you wanted to implement that in your care setting for a different activity that you see a lot of challenges.
Yeah, you mentioned that they're the same acronym or those same principles could relate to other aspects of care in terms of activities of daily living, and that really makes sense. Mary Joy comments that the recipe principles can also be customized and used in the home setting, especially in LMICS. I'm not quite sure what that is. Like Kenya, where the older adults and those with dementia are cared for at home by their immediate family members. So, using those same principles, whether you're in a formal care setting, like a nursing home, or whether you're an informal care partner, like a family member taking care of their loved one at home. So, so Sarah's saying, if you can, please include the bibliography on the recipe manuscript in the email tomorrow. I think you said you were in the development of.
Yeah, we are revising the manuscript, so we don't have a link or a DOI yet. But I can share some of the documents. It's okay. I think I can share that, although it's part of the manuscript, but I think it would be fine. And once we get that hopefully accepted or impressed, I'm happy to share that again with the group. Now it will be just pieces or like a table or a couple of appendices that I can share so you can see what it's about.
And towards the beginning of your presentation, Dr. Liu, you talked about examining the facilitators as well as the barriers. And I think, you spoke about those as you progressed with your presentation, but you mentioned, some specific findings. Could you elaborate on that a little bit? What did you find as some of the barriers, as well as some of the facilitators?
Yeah, some of the barriers that care staff find at different levels. One is the resident level. I think that could probably echo with a lot of your observations who are really working or have exposure, have interacted with people living with dementia. At moderate to severe stage, their condition kind of change or their status kind of fluctuate over time, day by day and meal by meal. Including the sundown effects, but there are other effects like for the lunch today and tomorrow, they might have slightly different performance. And then they could perform well today, but not so well tomorrow. So there seems to, from care staff, perspective, the barriers is like you need to keep, you know, you need to consistently evaluate where the resident is with mealtime. And that's very challenging for them with the time and their expertise that they have, all the level of training they have. Oftentimes care staff could get confused as well, especially those who are new. Um, so fluctuation, day by day or meal by meal is the primary barrier care staff has mentioned. But the strategies they have been using, or the facilitators are really like they have a group, they learn from each other, peer support, and they get to know the resident day by day. So if they were not able to get it with one resident, they also learn from different residents and they can quickly kind of grow out of that and learn all the strategies. They do a lot of try and error. If this is not working, I try a different approach. And maybe the next day I come back to the same approach. And also they reapproach the residents at different times through different ways. So it's a lot of try and error that comes with sometimes frustration, but also feelings of success because it is challenging essentially. So, and there are also some other assistants they're using like instrumental type of assistance, also verbal, nonverbal, physical assistance that they're providing, and also trying to, kind of look at the whole environment, what's the best for this particular resident. Um, so a lot of care staff is making efforts to learn from each other, learn from the residents, but also, learning day by day. That's something they were saying the most. And I can share that full text as well, where, there's a lot of quotes that we used from the care staff. And also we, synthesized what we learned using the same multi-level model of the social ecological model. So hopefully that will help you to understand what are the different factors at different levels and which can be modifiable, which can be, improved or changed over time. So.
Yeah, your multi-level factorial approach is amazing because, you were talking about the interpersonal aspects and, each person, if you've met one person living with dementia, you've met one person living with dementia, right? So, just getting to know that person as an individual, their cognitive status, their functional state, that's a lot of information to take in and analyze on a regular basis. But then that interpersonal piece, one of the things I remember you commenting on was that sometimes staff are very task focused versus really being preference or person centered, in their approach. Can you comment a little bit more about what you observed there?
Sure. It's interesting, Janice, you talked about task-centered versus person-centered. I think I'm learning as well, or changing my attitude toward mealtime care, person-centered care as I learn about all of those, what's really happening. I thought person-centered care is the best for everything. That's what I came from. And then I realized it helps with some but not necessarily help with some other aspects like person-centered care does not necessarily reduce challenging behaviors. And, challenging behaviors, maybe it's not something that we want to really minimize. It's really something we need to understand it and then, respond to it. Rather than, I came from a perception that, oh, I need to reduce or all the challenging behaviors. So people living with dementia don't have any challenging behaviors when they are eating meal. That's not going to happen anywhere. That's my philosophy at this point. So I'm changing. I feel like although you are performing person-centered care throughout the whole meal, you may still observe some of the resistive behaviors because residents don't understand. They may not think that's a person-centered approach. They were indicating or communicating with you their needs, which were not addressed, from the care you were providing at the moment. So I think a changing philosophy from that resistive behaviors is something to minimize to it's something that communicates something, and we need to understand that and respond to that. It's something that I'm holding on right now with residents challenging behavior, and person-centered care is not really the cue for everything or the one-size-fit-all approach. And also task-centered care, it's not something we want to completely remove from mealtime care. It's something that's needed because we are, care staff is really helping the resident to eat more. If they're not going to eat any, that's not going to be good. That's not going to keep or maintain their nutritional, status or weight, which can lead to a lot of severe outcomes, like Janice, you initially shared about losing weight, for people among people living with dementia, which is very dangerous. So mealtime itself and all other activities of daily living, they come with a goal to complete a task for the resident. But hopefully, during the process, we could engage the resident as much as possible rather than just simply for the goal of completing the task of bathing or feeding the resident. There should be more about it. So I think I see mealtime being a combination of both person-centered and task-centered, but when we try to complete the task, we also consider the residents' ability, how much they can engage. I think I kind of think it more as a mixture of both for all types of care. And I don't feel ashamed if I were delivering some task-focused care when I'm still considering the residents' needs. I think that's good. I hope that makes sense. It gets confused.
Yeah, it does. I think, you're describing really the interpersonal kind of connection and dynamics that are going on as a person is experiencing their meal. And, for the care partner to be responsive to what's going on for the person with dementia. They might be, displaying some sign of a distress or an unmet need, maybe they need another drink of water or, whatever it is, and seeing that in not as a challenge or a behavior, so to speak, but more as that they're trying to communicate something to you. And so, making sure that you're interacting in a way that's responsive, to their needs. That totally makes sense. So we're close to the end of our time. I wanted to comment as well, Dr. Liu, about, some of the information you shared about next steps. The tools that you described you were working on in collaboration with others, helping to create decision-making guidelines, helping to promote hydration because we know, dehydration and delirium can be a significant problem in older adults with dementia, as well as, developing kind of a framework for evidence-based interventions to be used at mealtime. All those resources are going to be invaluable, to everyone, listening today, but, well beyond this group. So thank you for the incredible work that you're doing. Thank you so much for being here and presenting your work to us today. I want to do a shout out to Leah Buck, who is the director of the SOME Center in Iowa, who was a former member of our CGNA leadership team. So Dr. Buck is an amazing gerontologist, and we're thankful for that she recommended that you present today, Dr. Liu. And I noticed that Dr. Marie Boltz and Kimberly Van Heitzma were on your lists of collaborators. So I'm pleased to see that they're working alongside this great work that you're doing. So thank you so much for all your time. Thank you to everyone for joining us today. As a quick reminder, please know that the evaluation tool will pop up in your browser when we leave the webinar, and Jenny will send it to you via email tomorrow as well. So thank you, everyone, and hopefully we'll see you at our next seminar.